Am I visible?
Nice, sir.
Okay.
We're good to start, sir.
Yeah. Hi everyone, good evening. On behalf of Yashoda Hospitals Emergency Department, welcome to our academic program, Expert Appraisal in Emergency Medicine. As a part of our academic activity, we will discuss Journal Club. As a part of Journal Club, we are going to discuss PREOXI trial, TRACE 3 trial, RISE trial. All three are the path-breaking trials recently published in New England Journal of Medicine. So I welcome Dr. Rajdeepan, Sandeep Reddy and Tarun to present today's journals. And first, I request Dr. Rajdeepan to present PREOXI trial.
Yes, sir. Good evening, everyone. Today we'll discuss about an important trial which was published just 2 months back, and it will be a practice-changing trial in as a ER physician. It was trial called PREOXI trial. It stands for a pragmatic trial examining oxygenation prior to intubation. Actually, this trial dealt with regarding the pre-oxygenation during rapid second intubation. Normally, for pre-oxygenation, we are using either NRBM or bag mask wall ventilation for pre-oxygenation with 15 liters or 100% oxygen. This trial dealt with either use of NIV versus oxygen mask, whether there is any benefit with the NIV or with the oxygen mask. First, we will discuss about regarding the basics of pre-oxygenation during RSI. Basically, rapid intubation involves 7 steps, and the second step, important step, is pre-oxygenation. First, we will discuss what is apnea time. Apnea time is the time between induction of anesthesia to till we secure the definitive airway. During this time, patient will not be able to breathe, and the oxygen should be there is increased incidence of hypoxemia during this interval. There is increased risk of complications, mortality, and morbidity. If oxygen saturation is less than 70%, there is increased risk of arrhythmias, decompensation, and cardiac arrest. So basically, to prevent this, we are pre-oxygenating every patient before rapid second intubation for at least 3 minutes. Basically, we are doing a pre-oxygenation with the NRBM or a bag mask valve with 100% oxygen for at least 3 minutes. So how does this pre-oxygenation helps to make apnea time into safe apnea time is that it displaces nitrogen from the alveoli and creates a potential oxygen reservoir so that it prevents the hypoxia and hypoxemia during that apnea time. So that the apnea time will be a safe apnea time, and there will be decreased incidence of hypoxemia and cardiac arrest. This PREOXI trial asked an important research question, which is about in critically ill adult patients, does the use of NIV for pre-oxygenation versus use of oxygen mask, which is a conventional method, does reduces hypoxemia during intubation compared to conventional method. So the basic objectives of this trial were regarding they studied regarding the hypoxemia during intubation, which is defined by saturation less than 85% from the induction of anesthesia till 2 minutes after intubation, and they have studied secondary outcomes regarding the lowest oxygen saturation and other hemodynamic events that could result from NIV, which includes hypotension and cardiac arrest. Coming to methodology, it was a pragmatic trial, which is a practical clinical trial, and it was a multi-center trial. It was a non-blinded parallel group randomized trial. Total sample size was first 4,567 patients were assessed for eligibility, out of whom 1,301 were randomized for this trial. It was done in USA, and it happened in 7 sites in ER and 24 sites in ICU. And it was done during the period between March 2020 to October 2023, and it was published just 2 months back, which is a path-breaking trial. The inclusion and exclusion criteria of this trial. The inclusion trial, patients who are more than 18 years of age, and the patients requiring urgent intubation, and the intubation involved the use of sedation and laryngoscopy. These are the inclusion criteria for the patients to include in the study. And the exclusion criteria were whether the patient is pregnant or a prisoner patient already on positive pressure ventilation, patient had apnea or hypopnea, depending on the operator whether to use NIV or oxygen mask, and patient who refused to consent for NIV use. The main methodology were patients were randomized in 1:1 ratio. There were two groups. Which one was the intervention group for which pre-oxygenation was done with NIV, and the second was control group for which oxygen mask was used for pre-oxygenation. And the study groups assignments were generated using a computerized randomization sequence as a part of randomization. Coming to the intervention group, in the intervention group, 645 patients out of 1,301 were randomized to the NIV group. For this set of patients, BiPAP was applied as a part of pre-oxygenation for minimum at least 3 minutes. And the BiPAP setting used were EPAP was more than 5 centimeter and IPAP was more than 10 centimeter of water, and FiO2 was around 100%, and the respiratory rate was maintained more than 10 per minute. Coming to the control group, in the control group, we did a conventional pre-oxygenation with the conventional oxygen mask. In this, 656 patients were randomized, and various combination techniques were applied for pre-oxygenation. Around 87.7% of patients were pre-oxygenated with the NRBM, around 12% were pre-oxygenated with the HFNO, and 13.7% were pre-oxygenated with the bag mask without ventilation, and 1.2% were pre-oxygenated bag mask with ventilation. Based on the study, data was collected. The data was collected by a clinical person on the settings or either research personnel. They collected data regarding a device used for pre-oxygenation, duration of pre-oxygenation, and the peri-procedural outcomes, and the oxygen saturation, either the hypoxemia is there or not, from induction of anesthesia till 2 minutes after intubation, and post-intubation complications. And the patients were followed up for a period of 28 days. First 24 hours, they observed for any new onset pneumothorax, new onset chest infiltrate secondary to aspiration, new onset vasopressor support, saturation, FiO2, and PEEP. After 28 days, the patient were observed regarding the 28 days in hospital mortality, and the duration of ventilator free days to 28 days, and the duration of ICU free days to 28 days. Outcome of the study, the primary main outcome studied was regarding the hypoxemia, which was defined by oxygen saturation less than 85% from the induction of anesthesia till 2 minutes after tracheal intubation. And the secondary outcomes and safety outcomes also studied. The secondary outcome was regarding the lowest oxygen saturation from the induction of anesthesia till 2 minutes after tracheal intubation, which will be less than 80% or less than 70%. And the other safety outcomes also has been assigned. And the safety outcomes include regarding the aspiration, regarding the FiO2 of inspired oxygen at 24 hours, and oxygen saturation at 24 hours after induction, and incidence of any new onset pneumothorax post NIV as pre-oxygenation, and new onset chest infiltrate as a complication of aspiration within 24 hours. And the results of the study were, out of 4,566 patients were assessed for eligibility, and 4,462 met the inclusion criteria. In that, 1,301 patients were enrolled. In this, tracheal intubation was done in ICU in 73.2% of patients, and the tracheal intubation in ED was done in 26.8% of patients. And the primary outcome, which I have already said regarding the hypoxemia, which was defined by oxygen saturation less than 85% from the induction of anesthesia till 2 minutes post tracheal intubation, it was the main primary outcome. And in the intervention group, which we have used pre-oxygenation as NIV, it was around 9.1%, and in the oxygen mask group, it was about 18.5%, which was almost a higher double in the oxygen mask group, which is the control group. And regarding the secondary outcome, lowest oxygen saturation was less than 80% in the intervention group of 6% people, and in the oxygen mask group, it was around 13%. And coming to the saturation of less than 70% in the as a part of a secondary outcome, in the NAV group, it was around 3%, and in the oxygen mask group, it was around 6 to 7%, which indicates that NIV is far better than pre-oxygenation. And other secondary outcomes include cardiac arrest, which was 0.2% in the NIV group and 1.1% in the oxygen mask group. And regarding the increased use of vasopressors, which is almost equal in both groups, around 17% approximately. And hypotension, which was defined by systolic blood pressure of less than 65 mmHg, which was almost less in NIV group, which was around 2.9% as compared to the conventional group, which was around 4.4%, which was much higher in the oxygen mask group. And other safety outcomes also has been studied. Other safety outcomes regarding the aspiration, out of 6 patients in the NIV group has been observed to develop aspiration, and 9 patients in the oxygen mask group developed aspiration changes. And a new infiltration on chest imaging was observed in 144 patients in the NIV group and 148 patients in the oxygen mask group. And a new onset pneumothorax was equal in both the groups, NIV and oxygen mask group. And the median oxygen saturation at 24 hours was 97% in both the NIV and oxygen mask group. Median FiO2 at 24 hours was around 40% in both the groups. And coming to the clinical outcomes, which was followed after 28 days, median ventilator free days was around 21 days in the non-invasive NIV group, which was a very good outcome. And the oxygen mask group, it was around 17. Median ICU free days were around 16 in the NIV group and 14 in the oxygen mask group. In hospital death regarding the mortality, which was around 209, around from 645 patients in the NIV group and 217 patients in the oxygen mask group, which is comparatively equal in both groups. So, based on the primary, secondary, and safety outcomes, we have got a conclusion from this study that among critically ill patients who are undergoing tracheal intubation, during pre-oxygenation, if we use NIV as a part of pre-oxygenation, it has resulted in very less incidence of hypoxemia during intubation than pre-oxygenation with oxygen mask group. As we have already seen that hypoxemia was around 9.1% in the NIV group and 18.5% in the oxygen mask group, which was almost double in the oxygen mask group. So it will be a practice changing trial. So we have to adapt change to NIV as a part of pre-oxygenation in a further future. And regarding the limitations of this trial, strength and limitations. Actually, before choosing a patients for pre-oxygenation with the NIV, this study has excluded certain group of patients like pregnant patients who are contraindicated for NIV, like pregnant patients, massive hemoptysis, epistaxis, and a massive hematemesis patient who are very increased risk of aspiration. So this set of who are already receiving positive pressure ventilations, this set of group of patients have been excluded from this study. So before we are thinking about pre-oxygenating a patient with NIV, we should meet this eligibility criteria. If this the eligibility criteria, apart from this, if it fits, then we can use pre-oxygenation with the NIV as a part of rapid second intubation, which will lead to very less incidence of hypoxemia as per this study. The strengths of the study were, it asks an important clinical question, and it was a multi-center randomized clinical trial. So there was that increases the generalizability of findings, and the sample size was very large, around 1,301 patients were assigned. So there will be clinically meaningful differences between the two groups. And a collection of outcome data, it was done by observers, so it decreases the observer bias. Some of the limitations which I already discussed in certain group of patients who are contraindicated for NIV, this study has not studied regarding the particular set group of patients like pregnant patients, vomiting, hematemesis, epistaxis patients, and it did not evaluate the use of HFNC for pre-oxygenation or apneic oxygenation. And the patients, clinicians, trial patients were aware of the study, so it might lead to bias also. And intubations were performed by residents or fellows, may not have much experience, so it may lead to some set of bias also. So coming to the conclusion of this study, so we have to opt to pre-oxygenation with the NIV in particular group of patients, and you have to carefully select patients for pre-oxygenating a patient with NIV, which has very lower incidence of hypoxemia. So we have to adopt this as a part of routine year works. Thank you.
Yeah. Yeah, that was a very good presentation, Dr. Rajdeepan. One main clinical question is, this is a study where we compared NIV with oxygen mask. Individually as such, HFNC was not compared. And in this study, we couldn't individually compare bag mask ventilation alone. In this, we included NRBM, or the other modes of BMV without ventilation, and other types of oxygen mask we included. So what do you think the risk of when we use BMV alone, or when we compare BMV or HFNC, how do you think the risk of aspiration changes when we use NIV?
Because NIV, when we use, there will be increased risk. There will be gastric. There will be pressure increase in the gastric pressure will increase. That may lead to aspiration, vomiting, and increased risk of aspiration. So, in particular set of patients who are pregnant, who are already risk of vomiting is there in head injury patients, hematemesis patients, or hemoptysis patient, in epistaxis patient, we should be little cautious and we should select cautiously set of patients.
Yeah.
Before
Based on the results of this study, I think definitely we can use NIV as an alternate option compared to bag mask ventilation with positive pressure ventilation and then HFNC. So yeah, definitely it was a path-breaking study. Thank you, Dr. Rajdeepan. That's a very good study and very good presentation.
Thanks.
Yeah. Now we will discuss next important study, Trace 3 trial. It was published in New England Journal of Medicine. I request Dr. Sandeep Reddy to present Trace 3 trial.
Yeah. Good evening, everyone. My name is Dr. Sandeep, President of Emergency Medicine, Yashoda Hospitals, Somajiguda. Today, we are going to discuss about the Trace 3 trials, which is rationally designed tenecteplase reperfusion therapy in the acute ischemic cerebral vascular events. It is a randomized and phase 3 open label control trial. Generally, the acute large vessel occlusion is associated with the ischemic, devastating ischemic tissue associated with the accounting for 30 to 40% of the ischemic strokes. So that the current American Heart Association guidelines recommends that intravenous thrombolysis bridging the mechanical thrombectomy for the acute large vessel occlusion of anterior circulation stroke within the 4.5 hours of stroke onset. So generally, the majority of patients arrive in the hospital outside the 4.5 hour time window couldn't receive the intravenous thrombolysis. So there is an extended time window to 9 hours for the intravenous LT place with the advanced imaging. So the time window for thrombectomy has been the guidelines endorsed for the treatment up to 24 hours in the selected patients with a clinical imaging mismatch. So although the LT-Place has been used in the clinical practice for since 15 years, it has main disadvantages delivery method of bolus followed by the drip for 1 hour. So it is generally drip and ship patients. So when you compare to tenecteplase, is genetically engineering mutant tissue is a plasmogen activator. So compared with LT-Place, the tenecteplase has a longer half-life, stronger affinity for the fibrin, and stronger tolerance to the plasmogen activator inhibitor 1 that can be administered as a single bolus. So there are so many methods. Study organization and design. There, the Trace 3 is a multi-center randomized open-label endpoint control clinical trial. Generally, we enroll the patient, assign in the ratio of 1:1 to receive the tenecteplase. So patients are required to follow for 90 days to assess the efficacy and safety outcomes. Patient population: adult patient with acute ischemic stroke due to culprit anterior circulation large vessel occlusion within 4.5 to 24 hours from the last known well within the salvageable tissue based on the CT perfusion or MRI were consecutively enrolled into these trials. So the patient with intents to proceed to endovascular treatment were excluded generally. So this is a inclusion and exclusion criteria where we are taking age more than 18 years old and the acute ischemic stroke within 4.5 to 24 hours prior to the enrollment, including the wake-up stroke, no witness patient, onset of time refers to the last and normal. The exclusion criteria is intends to proceed endovascular treatment and allergy to the tenecteplase. One is the rapidly improving symptoms at the discretion of investigator. So there is a persistent blood pressure elevation. The systolic is more than 180, diastolic is more than 100, despite the blood pressure lowering treatment. When you came to inclusion criteria, the pre-stroke modified Rankin scale less than 1, And the exclusion criteria is blood glucose less than 2.8 on random testing is acceptable. So then generally we'll do the baseline assessment based on the demographic information, based on the medical history, current medications, laboratory test, and baseline stroke severity. That is NIHSS score. And one more is a modified Rankin score, Rankin scale. And one is a CT perfusion that required to assess the target imaging mismatch. So this is a modified Rankin score scale with 0 to 5. 0 is no symptoms at all. Score 1 is no significant disability despite the symptoms, that able to carry out all usual duties and activities. Score 2, slight disability, unable to carry out all previous activities, but able to look after their own affairs without assistance. When you come to score 3, it is a moderate disability, required some help, and able to walk without the assistance. Score 4 is moderate severe disability, but unable to walk without the assistance, but unable to attend own bodily needs without the assistance. When you come to score 5, it is severe disability. It is bedridden, requiring the constant nurses caring and attention. Then we come to one of the methods, is randomization and blinding. Generally, patients are randomly assigned in 1:1 ratio to receive the 1080 place. The patients are stratified based on the site of vessel occlusion in the following one of the strata. One is the internal carotid artery occlusion and middle cerebral artery M1 segment and middle cerebral artery M2 occlusion. So when you come to treatment intervention, patient who received 0.25 mg of 1080 kg for body weight before the procedure, each vial of 1080 is reconstituted with 3 ml of sterile water for injection and suction according to their body weight and inject into bolus intravenously over 5 to 10 seconds. In that, there is a control group where we use the standard medications. One is the antiplatelet therapy. Generally, aspirin is combined with clopidogrel, or aspirin alone or clopidogrel is given on the discretion of local investigators. So, patient for whom direct endovascular treatment is planned, these medications are excluded from the study at initial assessment. So when you come to the concomitant management, although enrolled patients are requested to administer in the stroke units or ICU, the participants will be provided to receive any drug that may influence the coagulation within 24 hours 24 hours steady drugs. So when you come to, if the intravenous thrombolytic is performed, then the antiplatelet drugs, anticoagulants, fibrolytic drugs, and thrombolytic drugs are and other agents that affect the platelet function, such as indomethacin and neuroprotective agents. Here, the deep vein thrombolysis prophylaxis with low dose molecular weight heparin is acceptable. So when you come to outcomes and follow-up, the study visits will be performing in at screening period, generally 4.5 to 24 hours before the thrombolytic therapy. 0 hour is a thrombolytic therapy, 24 hours, 36, 72, day 7 or before discharge. At the screening period, generally CT perfusion that should be completed to assess the recanalization. The follow-up imaging with CT or MRI should be completed within 24 to 36 hours to detect the intracranial hemorrhage. So this is a flow chart. The symptoms presenting onset 4.5 hours, including the wake up and unwitnessed stroke, based on the strata, internal carotid artery, middle cerebral artery inclusion. This standard medical treatment where we take the 24 hours, 36 hours, 72 hours, 7 days. So this is a trial flow assessment flow chart where we will take the onset of time, thrombolysis, and we'll based on the blood pressure thing, demographic data. We'll all consider all these things. Generally, the key points include here. This is the hospitalization time and thrombolysis time, and the baseline is the blood pressure. So there are two types of primary outcome and secondary outcome. Primary outcome is generally the next, proportion of excellent functional outcome defined as a modified Rankin scale is less than 1 at 190, 90 days, and secondary outcomes are two outcomes, what is efficacy and the safety outcomes. So when you come to efficacy outcomes, the ordinal distribution of MRS is at the 90 days. So the proportion of favorable functional outcome, defined by the modified score less than 2 points at 90 days. Generally, the clinical response rate at 72 hours is defined as an improvement in the NIHS score more than 8 points when you compare with the initial deficit or a score less than 1. The rate of improvement on reperfusion at 24 hours is improved by 90% on Tmax more than 6 seconds. Generally, the NIHS is changed from baseline at 7 days. When you come to safety outcomes, proportion of within 36 hours, the rate of death at any cause within 90 days, and the rate of systemic bleeding at 90 days, and rate of the scales within 90 days. This discussion is that the trial 3 is the first phase 3 randomized trial in the late window period of 4.5 to 24 hours with a wake up or no witness patient who had a stroke due to large vessel occlusion that are not intended for endovascular treatment. Many patients in low income and middle income countries, thrombectomy is not option due to financial burden, but there are lack of routinely available advanced perfusion imaging is there. And the intravenous thrombolysis, the global foundation therapy for acute ischemic stroke management, is more affordable compared to this one. So it has tenecteplase has a superior pharmacodynamic and pharmacokinetic properties when you compare to LTplase. Here the diffusion and perfusion imaging evaluation for understanding the stroke evolution confirm that the mismatch could predict the favorable outcomes after TPA therapy within 3 to 6 hours. There is an extant trial for target imaging mismatch that demonstrated by the tenecteplase within 4.5 to 9 hours that could improve the reperfusion. Currently, the evidence of tenecteplase in later window is limited. Then the tenecteplase with wake-up stroke ischemic trial found that the treatment with the tenecteplase within 4.5 hours of awakening does not lead to better functional outcome at 90 days in the patient with wake-up stroke. So in conclusion, the trace 3 is initiated to investigate the efficacy and safety of tenecteplase beyond the 4.5 hours in a patient with acute ischemic stroke due to large vessel occlusion. It will provide the evidence of tenecteplase use in window of 4.5 to 24 hours. Thank you.
Yeah, that was really a path-breaking study, especially in a country like ours, where the time they reach the hospital, it is almost more than 4.5 hours. Most of the time we see that the only thing what we can do is give them antiplatelets. So if we can see that the results are favoring, then we can definitely initiate tenecteplase after 4.5 hours to till 24 hours. So we have to see, we have to wait for the results. I think phase 4 is ongoing. So we have to see, really it will become a path-breaking trial. So yeah, thank you, Dr. Sandeep. It was a very good presentation. Now I request Dr. Ram Tarun to present RISE trial.
Good evening, one and all. Myself, Dr. Tarun Reddy from Yashoda Hospital, Malakpet, final year of emergency regime.
So Dr. Ram Tarun, when was this trial published, RISE trial?
So it was published in June 27, 2024.
Okay, where it was New England Journal of Medicine, right?
Yes.
Yeah. I think it was like rationale of using retiplase in thrombolysis, right?
Yes, sir. Retiplase was Retiplase.
It was a very good study. Just continue.
Yes.
Okay.
Good morning, one and all. Today we are going to discuss. Good evening. We are going to discuss about the RISE trial. This RISE trial is mainly conducted between the retiplase and the altiplase for the stroke. As we all know that the stroke is the second leading cause of the death worldwide and is a major contributor to the disability. And a simplest form of the definition of the stroke is an acute episode of the focal neurological dysfunction that persists for more than 24 hours. There are two types of the strokes. They are ischemic and hemorrhagic. The ischemic consists of about 87% of the entire strokes, and they are of three types. They are thrombotic, embolic, and hypoperfusion. And the hemorrhagic stroke, they are of two types. They are intracerebral and non-traumatic SAH. Coming to the introduction of this trial, the treatment of the acute ischemic stroke relies heavily on mainly on timely reperfusion, which has been proven to be the most beneficial strategy. The intravenous alteplase is a thrombolytic agent that has been a cornerstone of acute ischemic stroke treatment for several years. Despite of its effectiveness, a relatively small percentage of the stroke actually receives intravenous thrombolysis. The retiplase and the tenecteplase are the third generation of the alternative thrombolytic agents. And today there is a lack of definitive clinical trials that are comparing between the retiplase and altiplase in patients with the acute ischemic stroke. The retiplase is a non-glycosylated variant of altiplase. The epidermal growth factor and fibronectin finger domains are absent in the retiplase. Because of this absence and the deletions extends the plasma half-life of retiplase that permits a double bolus regimen with fixed dosage, and it is easy to administer and more affordable than altiplase. Theoretically, the reduction in the fibrin specificity of the retiplase compared to the altiplase can enhance thrombolysis, and there is high chance of bleeding. The aim of this study was to compare the safety and efficacy of two doses of the retiplase with standard altiplase in patients with acute ischemic stroke who are eligible for the intravenous thrombolysis within 4.5 hours from the onset of the symptoms. Coming to the previous trials, the most of the previous trials are conducted between the retiplase and the altiplase in myocardial infarction rather than in the acute ischemic stroke. Those are the Gusto 3 trial. The Gusto 3 trial concluded that retiplase is as effective as altiplase in treating acute myocardial infarction. And the Rapid 2 trial it says that the retiplase of the double bolus of 10 regimen 10 plus 10 mega units to the patients with acute myocardial infarction achieves significantly higher rates of early reperfusion of the infarct-related coronary artery and requires significantly fewer acute coronary interventions than front-loaded altiplase without an apparent increased risk of complications. The important to the research question of this topic is to assess whether a double bolus of the retiplase would be non-inferior to the standard altiplase in achieving excellent functional outcome at 90 days among eligible patients with acute ischemic stroke. Coming to methodology, it is a multicenter open-label non-inferiority phase 3 randomized study among 1412 patients, which was conducted at 62 sites in the China between the time period of March 2022 to June 2023, and the duration of the follow-up is 90 days, and the median patient age is 63 years, and the percentage of the female is 29%. In the study, the inclusion criteria is age is between the 18 to 80 years, and acute ischemic stroke diagnosed based on the symptoms and intracranial imaging. Last known well time is less than 4.5 hours, and the pre-stroke modified ranking score is less than 1, and NHS score is between 4 to 25. The exclusion criteria is prior or current intracranial hemorrhage or any other intracranial anatomical abnormality, and NHS score greater than or equal to 2, and intracranial or intraspinal surgery, cerebral or other severe trauma, or any other stroke less than or equal to 3 months prior. And if patient is undergoing any prior endovascular recalculation therapy, and patient is having the platelet count less than 1 lakh, and is there any taking of the anticoagulation medicines less than 24 to 48 hours prior, and is there any high risk gastrointestinal pathology less than 3 months prior. And despite of the taking antihypertensive medications, if BP is greater than 185 by 110 mmHg, then those patients are excluded from this study. Coming to the intervention, among 1412 patients who were eligible for intravenous thrombolysis within 4.5 hours after stroke onset were assigned to receive intravenous retiplase on dosage is 18 mg bolus given over 2 minutes, followed by 30 minutes later by a second 18 mg bolus, or intravenous altiplase at 0.9 mg per kg given over roughly 60 minutes. Outcomes, the primary efficacy outcome of the study is proportion of the individuals attaining an excellent functional outcome defined as modified ranking scale. The score is between 0 to 1 at 90 days. And the secondary efficacy outcomes encompass favorable functional outcome defined as modified ranking scale 0 to 2, and the major neurological improvement on the National Institute of the Health Stroke scale, ordinal distribution of the modified ranking scale, and Barthel index score of at least 95 points at 90 days. The primary safety outcome or symptomatically intracranial hemorrhage at 36 hours within 90 days. Coming to statistical analysis, with the assumed 62.5% proportion of the primary outcome for altiplase, the determined sample size is about 14 to 12, like 706 in each treatment group, which provide 80% power, allowing for a 3% drop rate at 90 days. The probability of at least one death or symptomatic intracranial hemorrhage occurrence was estimated to be 99% among 14 to 12 patients, based on the incidence of the symptomatic intracranial hemorrhage and death among the patients with acute hemorrhagic stroke. The data will be presented as mean plus or minus standard deviation or median for continuous variables and counts for categorical variables. Efficacy analysis will be conducted in the modified intention to treat population. The primary outcome is to measure the proportion of the patient with modified Rankin scale 0 to 1 at 90 days, and analyzed by calculating the relative risk of altiplase versus retiplase using log binomial regression. If altiplase is non-inferior to the retiplase, if the lower boundary of relative risk is greater than 0.93, altiplase is superior if the lower boundary of the relative risk is greater than 1. Coming to the study outline, it is conducted between the 2022 to 2023 from 62 sites of the China, among which 707 patients assigned to receive retiplase and 705 assigned to receive altiplase, with the exclusion of the 13 patients who did not receive either the altiplase or the retiplase. The demographic variables under the study are age, sex, coexisting conditions, and NHS score at admission, and modified Rankin score before the index stroke, time from symptom onset of the administration of the retiplase or the altiplase. The median age of the patients is 63 years, and in which the most are men, about 70.5%. The median NHS score was 6. The median time from the stroke onset to the administration of the altiplase or the retiplase was 180 minutes. A total of the 45 patients, in which 20 in the retiplase group and 25 in the altiplase group, received rescue thrombectomy. Coming to the outcome, the primary outcome is a modified ranking scale score of 0 or 1 at 90 days, and the secondary outcomes are modified ranking scale score of 0 to 2 at 90 days, and the median modified ranking scale score at 90 days, and early dramatic recovery at 24 hours, and early dramatic recovery at 7 days, and Barthel index score of greater than 95 at 90 days. The interpretation is like the primary outcome, the 90-day modified ranking scale of 0 or 1 was 79.5% in the retiplase group and 70.4% in the altiplase group. And the secondary outcome, it is a good functional outcome, was reported in 85.3% of the patients in the retiplase group and 79.8% of those in altiplase group. The other secondary efficacy outcomes were all improved in the retiplase group. In the safety population, the symptomatic intracranial hemorrhage within 36 hours occurred in 2.5% in the retiplase group and 2% in the altiplase group, and death within 90 days occurred in 4.3% in the retiplase group and 3.4% in the altiplase group. The other safety outcomes include symptomatic intracranial hemorrhage within 7 days, within 90 days, and serious adverse event within 90 days were similar in the two trial groups. Coming to the discussion part, the retiplase was found to be non-inferior to the altiplase in achieving excellent functional outcome at 90 days with a 9.4 percentage point higher success rate. There were no significant differences in the rates of the symptomatic intracranial hemorrhage or mortality and safety profile between the retiplase and altiplase groups. The retiplase group showed an higher incidence and adverse events of any intracranial hemorrhage at 90 days of the study. Retiplase may improve functional outcomes without increasing symptomatic intracranial hemorrhage or death, with a higher percentage of the patients experiencing the early dramatic recovery. Prior study shows that tenecteplase is non-inferior to the altiplase, but no direct comparison exists between the tenecteplase and retiplase, indicating a need for head-to-head trials. Both retiplase and the altiplase groups had better functional outcomes in the RACE trial compared to the previous trial, possibly due to the factors like an higher prevalence of atherothrombosis, younger patient age, and lower NIHS score. Research on the retiplase in myocardial infarction suggests double bolus administration could enhance reperfusion and reduce rethrombosis, warranting further exploration of the stroke treatment. The limitations of the study are the trial, even though it was an open label, which can introduce biases despite random patient assignment and blinded outcome assessment. Testing for the superiority after non-inferiority might weaken the statistical support. 3% of the primary outcome data was missing and had to be estimated for analysis. The participation limitations are, it is conducted in China, and the limitation is like patient who is having the age greater than the 80 years old, and women were also underrepresented in this study. The conclusion is like retiplase was found to be more effective than altiplase in achieving excellent functional outcome at 90 days, but there is higher rate of intracranial hemorrhage.
Yeah, thank you, Dr. Ram Tarun. That was a great study. So more take-home points are that retiplase, of course, compared to alteplase, the ease of administration is very good with retiplase. And then concern is safety outcomes. So what do you say? So days where we are using more of tenecteplase is where we are using more tenecteplase. Do you think retiplase outcomes are comparable to tenecteplase?
Actually, there need to be get further more studies here. Because of that, the retiplase has higher chance of the bleeding. So they need to conduct like we
Yes.
need to get more studies on that, whether the
Definitely.
retiplase will work better or not. Like
Compared to alteplase, functional outcomes are definitely better, but safety concern is there. So I think if retiplase is not inferior to alteplase, then there will be studies conducted comparing tenecteplase to retiplase. Yeah, thank you, Dr. Tarun.
yes, thank you.
So today with this we end our journal club today. Thank you everyone.
Well, close.